There are two pipes leading down the throat from the back of the mouth. One is the gullet, or esophagus, which leads to the stomach, and through it pass our food and drink. The other is the windpipe, or trachea, which leads to the lungs and carries the air that we breathe in and out. The larynx, which produces voice, is situated at the entrance to the windpipe. It's protected by the epiglottis, a flap of tissue that stops food going down the windpipe, going down the wrong way. When the larynx is removed, the gullet and windpipe become completely separate tubes, with the throat connected to the gullet. But the windpipe comes out through a new opening in the neck, the stoma. From now on, all breathing takes place through the stoma. The nose and throat no longer take part in breathing or coughing. Phlegm is coughed out through the stoma. Eating is in the normal way. But since you've had the voice box or larynx removed, you need to learn another method of producing a voice. Because the back wall of the larynx is also the front wall of the upper gullet or pharynx, the pharynx has to be repaired to make it a tube again. This has to be allowed to heal before swallowing is possible.
After somebody has had a laryngectomy, they only have one tube from their mouth going all the way down to their stomach. Their airway is permanently brought out at the base of their neck in what is known as a tracheostoma. That is their trachea, and that goes down towards the lungs. Thereafter, there is one tube to the stomach from the mouth and one tube from the stoma down into the lungs. The only time the two connect is when the patient has a voice prosthesis or a speaking valve. A puncture is made at the back of the stoma to make what is known as a tracheoesophageal fistula. The voice prosthesis or valve sits in this fistula and connects the two to enable speech to happen after laryngectomy.
I am speaking with a valve, sometimes called a voice prosthesis.
The third type of voice the paramedics may encounter is a electronic larynx, sometimes called a Servox. That's a brand name, the most commonly used in the UK.
My method of communication is by using the artificial larynx.
There's no point in applying air or oxygen to the nose or mouth of someone who's had a laryngectomy, as these are no longer connected to the lungs. It's essential that oxygen is applied to the stoma. For a first aider, that means mouth-to-neck resuscitation is the only effective technique. Of course, it's a good idea to use any available means of separating yourself from the patient.
Hi, are you okay, Ra?
Yes.
What's happened?
It's collapsed.
Because a paramedic can never assume that a laryngectomy will show up on the system,
Molly.
it's essential that they make it common practice to check the neck and chest area of any patient in case there's a stoma present.
Okay, would you mind getting us a little tea towel or something,
No
mate,
problem.
if you don't mind, yeah?
What we got, Mark?
Right, there's a neck breather. No, I think there's something stuck inside our neck here.
Right.
You got that tea towel, mate? That's great, thanks very much. Has your wife got any other medical problems, asthma, diabetes?
Raising the shoulders
Or
allows the head
like
to
that?
roll back, giving better access to the stoma in the neck.
Okay, she's got a little blockage in here, I'm just going to remove it. Okay, that's that. No, it's not breathing, Jeff, and you have to bugger.
There you go, mate. I'll get a chair.
Okay, cheers, mate.
When a paramedic's resuscitating a patient with a bag valve mask, they could use a paediatric mask, a circular mask that comes in different sizes. Alternatively, they could use an adult mask, which they just need to turn to the side so they can occlude the stoma and cover the neck with that.
Hello there. How are we doing? You remember what's happened to you?
When a paramedic resuscitates a
No.
laryngectomy or
Well, a little
tracheostomy
bit of a
patient,
ponytail, all right.
all the dressing should be removed from the neck. The stoma or tracheostomy tube should be completely exposed, and resuscitation should take place via the tracheostomy with closure of the mouth and nose.
Some outer covers may look just like clothing. It's only once these have been removed that you can see any other covers, and finally reveal the stoma itself.
It's important to occlude the mouth and nose because in tracheostomy patients they still have a pathway from the mouth and nose into the lungs.
For any paramedic or first aider dealing with someone who's had a laryngectomy, there are some vital points to remember. First, check to see if the patient has a stoma. Wipe away any mucus or crusting that could be blocking the stoma. Check the stoma for blockage and for signs of breathing. Raising the shoulders will tilt the head back, giving much better access to the stoma. Remember that the small plastic valve, which is often present in the wall of the trachea, is meant to be there and should not be removed unless it's causing a blockage. It's vital that the upper airway is closed, whether the patient is a tracheostomy or a laryngectomy. This is to prevent air escaping if there's some connection left to the upper airway, as can be the case in a tracheostomy. Oxygen or air must always be applied to the stoma, the opening in the neck. If there is no specialist mask available, a pediatric mask can be used, or a regular mask turned through 90 degrees.